as I hobble my way up here. Good morning, everybody. So thanks to Chris, I quickly realized today that I am not technologically advanced enough. So I do have some questions for you guys, but we're going to do it the way old school way of just we're going to raise our hands, right? So how many people in this room have heard of physical medicine and rehabilitation? Oh yeah, this is great. How many of you have heard of or interacted with cancer rehabilitation medicine? All right, we're doing a good job here then. Great. So being not technologically advanced, how do I? Just the big green button, that's great. Makes sense. So I titled this talk, Always Saving Lifestyles. We love our oncology teams because they save our patients' lives, and then we take the claim of saving lifestyles for our patients in cancer rehabilitation medicine. So no disclosures today. Disclaimer, I do speak pretty fast, so give me a little ear tug right here if you need me to slow down. So just a quick introduction, because a lot of you here know what physical medicine and rehab is, but a lot of folks don't, and I feel like half of my job is always trying to explain to people what I do. So we are real doctors. Went to med school for 4 years, did PM&R, physical medicine and rehab training. I did that in Rochester, New York, and then there are a number of cancer rehab fellowships. I did mine at Sloan Kettering in New York City, where I stayed on board as an attending before realizing that I'm not a multimillionaire and I'm not in my 20s, and New York City probably wasn't going to be long-term for me. So here I am in Denver now. So we're going to talk a little bit about what is cancer rehab medicine. I'm going to define it, talk about the history, the models of rehabilitation, and the role of a cancer rehabilitation medicine physician. And then I have 2 clinical scenarios for you all that we're going to go through. So over the years, again, we've struggled with defining not only PM&R, but cancer rehab medicine, and we've had a number of different iterations of this definition. Dr. Silver coined this. She's one of our cancer rehab colleagues over in Spalding in Boston, and she defines cancer rehab as cancer rehabilitation is medical care that should be integrated throughout the oncology care continuum and delivered by trained rehabilitation professionals who have it within their scope of practice to diagnose and treat patients' physical, psychological, and cognitive impairments in an effort to maintain or restore function, reduce symptom burden, maximize independence, and improve quality of life in this medically complex population. And I've highlighted here the 2 parts that I love the most about this definition is that we should be present throughout the entire cancer care continuum, and then our goals. We want to make sure that our patients are able to function in their day-to-day. I tell my patients all the time, I want you to be able to do the things you need to do, but also the things that you want to do, right? That's the important part of this. So PM&R has done a terrible job at marketing. So back in the 1920s is when we first came about, but we called ourselves doctors of physical therapy. So that's confusing, right? So 1923 and 1938 were the years that we first had our national organizations, APM&R and ACRM. In the 1940s, I feel, is when PM&R really started to get more popular as our soldiers were coming back, and we really needed to reintegrate them into their day-to-day, and not only what they needed to do, but what they wanted to do. In the 1960s and 70s, there was a lot going on in the government. A lot of legislature acts came through, the Heart, Cancer, and Stroke Act, the Rehabilitation Act, and the National Cancer Act. All of these promoted rehab to a certain degree. And then also during these decades was when MD Anderson and Sloan Kettering first had their PM&R services established. And then fast forward to present day, we have 9 cancer rehab fellowships across the US. I have to update the slide because there's one in Canada. And it goes, so I did my fellowship 5 years ago. There were 5 cancer rehab fellowships, and now there's 9. So I would say that's pretty quick movement, and I anticipate that to continue to move forward. So where are we in the nation? I was part of the problem on the East Coast. We got a ton of people on the East Coast. We have one in Kansas, that's the nearest one, to me, one in Tucson, and then me right there in the middle. But you see the dearth of, we don't have folks in the mountain regions. We don't have folks that many in California on the west side, right? So we got a lot of work to do here. So Dietz's classification, when you look up cancer rehab medicine, you see the models of practice, and Dietz was the first one to coin this. He was the chair of the rehab program at Sloan Kettering back in the 60s and 70s, and so he coined this model of care of, again, cancer rehabilitation should be offered and integrated throughout the cancer care continuum. So there's 4 stages. We have prehabilitation, we have restorative rehabilitation, supportive rehabilitation, and palliative rehabilitation. And so again, going through the oncology care continuum. So prehabilitation, or what we commonly say as prehab, is when a patient is diagnosed with cancer before their active treatment, whether that may be surgery, whether that may be chemotherapy, radiation, or now, right, immunotherapy is the next big hit. So here we focus on really establishing a good functional baseline. How are these patients doing in their day-to-day? Were they using an assistive device before? Do they have like wicked knee arthritis? Did they have a tibial plateau fracture that they need to wear a brace for, like me? So we really want to get an idea of where they're at functionally so that we can set them up for success as they're undergoing treatments. But that's why we identify impairments, and then we provide interventions that can promote physical, psychological health to reduce the incidence of impairments moving forward. Then we have restorative rehabilitation, which is usually at this point kind of after surgery, during active treatment, when we're still focusing on a curative intent. Here we focus on returning patients to their previous levels of function within the realms of the physical, psychological, social, and vocational. Supportive rehabilitation is when cancer treatment results in permanent or likely permanent deficits. And our goal here then is to reestablish functional independence. We want to focus on increasing self-care abilities, not only for our patients, but also for their caregivers to decrease some of that burden, right? And we want to prevent any complications of disuse. So, for example, we have patients who get a stem cell transplant. They're in the hospital for months, 2 months, right? They're deconditioned. They can develop contractures if they're not moving around. They can develop ulcers. All these types of things can happen when we decrease our mobility. So we want to focus on that in this stage. And then palliative rehabilitation. I don't think that we're thought of this much in the palliative stage. Obviously, palliative medicine is thought of more, right? But here, right, we're still focusing on improving quality of life. I've had patients who are in the palliative stage, maybe have 3 or 6 months per their oncology teams. They want to know, is it safe to exercise? How can I exercise? How should I move around? How should I be doing things? There's still goals that they want to achieve, and we need to focus on that as well, and this is where we come in. So the role of somebody like me, a cancer rehabilitation medicine physician, it's multidisciplinary. You've heard this in both talks today. You've seen some iteration of this diagram already twice today. It really does take a big team, and I always tell my patients, you guys are the MVPs, and we're here trying to help you move forward, right? So obviously the oncology teams, PM&R, our therapists, PT, OT, speech, lymphedema, pelvic floor, nursing, APP staff, pain management, psychiatry, psychology, and other supportive services. So when a patient comes to see me, they may be referred over for shoulder pain. I'm going to focus on that shoulder pain, but if it's a patient with breast cancer and they're on aromatase inhibitors, they had surgery, they had all these other things, I'm going to take that into account to think about all the other things that can happen, whether it's lymphedema, do they have aromatase inhibitor musculoskeletal syndrome, do they have radiation fibrosis, do they have chemotherapy-induced neuropathy? I'm focusing on all of this, taking into account their treatment and then what they're telling me in a physical exam. So I really want to do a comprehensive functional, neurologic, and musculoskeletal evaluation. I can help with assisting different types of impairments. We all know that shoulder pain isn't always shoulder pain. It can come from the neck, it can come from the elbow, right? So trying to do a good exam to help identify these impairments. One of my favorite things that I do, obviously working in this multidisciplinary fashion, is helping the oncology teams determine which treatment plan is most appropriate based on their functional status. For example, is this patient who we're recommending a bone marrow transplant functionally able to handle a bone marrow transplant, right? Another example, patient with osseous Mets, bony Mets, is this one causing pain? Is this one causing pain, right? On a physical exam, we can figure that out, and then they can zap that, right, with radiation oncology. Obviously, I work very collaboratively with our skilled therapists, so I provide detailed skilled therapy prescriptions. It's not just your eval and treat. I'm telling them exactly what I want them to do, and then I'm a big fan of communication. I'm a self-proclaimed over-communicator, so I work really closely with our therapists because we know that it's not just one linear road, right? Bumps can come along the way, and we have to tackle that as well. When patients don't need skilled therapy, I can provide an individualized exercise prescription. We have recommendations from the American College of Sports Medicine on what type of exercise and what script of exercise patients need to do for a number of different things, including cancer-related fatigue, lymphedema, all of that. So I can help patients with that. I do non-opioid pain management, so this looks like a lot of nerve stabilizing medications, antispasmodics, things like that. Orthotics and prosthetics, AFOs, posture braces, and then different types of interventional procedures. You'll see this vary across the nation depending on the cancer rehab physician and their training, but I'll do a lot of Botox, for example, for trismus, for radiation fibrosis, or cervical dystonia from radiation fibrosis, also in the chest wall for patients with breast cancer. I'll do steroid injections into your major joints, trigger point injections, those types of things. Other cancer rehab doctors may also do different types of nerve blocks. A patient with post-mastectomy pain syndrome may require a PEC block, a serratus block, those types of things. So it varies a little bit across the nation. So non-exhaustive list of diagnoses I see. We're obviously not going to talk about all of these, but essentially anything that falls within the realm of the musculoskeletal and neurologic systems, right? So just common things, chemotherapy-induced peripheral neuropathy, one of the most common side effects of chemotherapy treatments. Obviously, our patients with brain tumors can present like a patient with stroke, right? And they can get pain into their shoulder if they have a droopy shoulder, things like that. Myopathy, steroid-induced, right? Our patients are gonna come in mainly with weakness into proximal extremities. Neuromuscular complications, again, with immunotherapy, it's great because it's more targeted, but then they can get all these weird side effects. We can get Guillain-Barré syndrome, myasthenia gravis, inflammatory myositis, things like that. Spinal cord injuries is something really big. I think in the cancer world, it's missed because we don't call it a spinal cord injury, right? We'll say cord compression, but then the patient has neurogenic bowel and bladder, and what do we do? So that's where cancer rehab can come in and help as well. Obviously bone tumors, post-surgical pains, post-mastectomy, post-thoracotomy syndromes, aromatase inhibitor musculoskeletal syndromes in our patients with breast cancer. Big thing obviously is lymphedema and radiation fibrosis. And then in the head and neck, there can be shoulder and neck dysfunctions, dropped head syndrome from radiation, trismus, which is the inability to open up your mouth. Obviously the big concept of prehab. Deconditioning comes in, cancer-related fatigue, cancer-related cognitive dysfunction. Now I went through the whole list after I said I wasn't going to. So there's always more to this though. So this list is just gonna keep on getting bigger. So here we go to our cases. The first one is going to be a patient with breast cancer, 56-year-old left-sided breast cancer. She had a mastectomy and an axillary lymph node dissection, followed by adjuvant chemotherapy and radiation therapy to the chest wall. She was started on anastrozole about 6 weeks ago and is referred to you for peripheral neuropathy. So again, I'm going to talk about this patient's peripheral neuropathy. I'm going to do a good exam to evaluate that peripheral neuropathy, but we're going to talk about a whole lot of other things as well. So what's running through my brain when I see this patient? This patient has surgery. Could she have some component of post-mastectomy pain syndrome? And essentially this is a misnomer because it doesn't only happen with mastectomies. It can happen with a lumpectomy, breast augmentation, breast reduction, any type of surgery in the area. It's essentially defined as, it's a diagnosis of exclusion defined as pain that extends beyond the normal post-op period, which is around 3 months or so, right? So I'm thinking about that. I'm thinking about lymphedema because they had an axillary lymph node dissection, which makes them at a higher risk for lymphedema than a sentinel lymph node dissection, and then they also got radiation. Lymph nodes are very radiosensitive, and I get a lot of patients who may have not had a high-risk surgical procedure, but got radiation, and then they got lymphedema months, maybe even like a year out later, and nobody knows why. It's because radiation is continuing to exert its effect on the lymph nodes, and that can cause lymphedema that presents a little bit later on. With the chemo, of course, we're thinking about peripheral neuropathy, radiation, this whole concept of radiation fibrosis. What I tell my patients is that radiation is great, we love it, yay, good to treat cancer, but as radiation is going to its target, it has to pass through skin, soft tissue, muscle, nerves, bones, lymph nodes, all these structures, and to different degrees can affect all these structures in different ways. And so when I think about radiation fibrosis, in the sense of the musculoskeletal system, it's tightening, hardening, scarring of the area. If we're thinking about a patient with breast cancer, all of this is just going to get tight, and they're going to say, I can't lift up my arm because it just feels wicked tight. And sometimes it is a rock solid tightness right into that pec. So that's with fibrosis. If we're thinking about also The breast area, we have our brachial plexus here. I have seen patients develop a full brachial plexopathy where this arm then becomes a non-functional arm from radiation damage. Again, this can happen years, even decades after, so it should always be on the radar in patients who have received radiation therapy. And then hormone therapy. With the aromatase inhibitors, we can get this concept of aromatase inhibitor-induced musculoskeletal syndrome. I wish somebody would have made an easier name for this. But the other name is aromatase inhibitor-induced arthralgias. I don't like using that one because it's not only arthralgias. You can get a carpal tunnel syndrome. You can get tendinitis with this as well. Usual onset is within 4 to 6 weeks of starting these medications, and this can be pretty severe. Patients can have really poor quality of life related to this. And sometimes it comes to the discussion of, do we have to switch to another aromatase inhibitor, or do we have to quit altogether because their quality of life is so significantly affected? So again, treatments for all of these, for all of these, you'll see PT, lymphedema therapy, all those types of things. Medications, again, nerve stabilizing medications, muscle relaxants for post-mastectomy pain, injections. I will Botox usually the pec, the upper trap, and then the teres major, the latissimus dorsi. The caveat with Botox is that it's not an FDA-approved diagnosis for Botox, so we kind of have to play the game a little bit and get insurance to approve this. But for the most part, we do get insurance approval and do this. For peripheral neuropathy, I tell my patients we unfortunately don't have anything to either prevent or reverse a peripheral neuropathy. And so what we do is, again, trying to get patients over the hump, because nerves do heal and nerves regenerate, and when you remove that noxious stimulus, there is some room for improvement. Studies show that about 68% of patients are going to get some degree of neuropathy during chemo. 3 months from completion of chemo, that goes down to 60%, so 68 to 60, not so much, but we got a trend. And then at 6 months, that goes down to 30%, right? So there is some trend, time is our friend, but that's not what patients want to hear, right? So how do we get them over the hump? Gabapentin, Lyrica, Cymbalta. Cymbalta has been the one to be shown in literature to be the most effective for chemo-induced neuropathy. It's not the one that we jump to the first, I feel, oftentimes. In the breast cancer world, there is a relative contraindication with Cymbalta and tamoxifen through one of these, I never remember the CYP or CYP pathway, one of those. So there is a relative contraindication with tamoxifen and Cymbalta. For the radiation fibrosis, again, PT/OT medications when it's painful, we kind of sometimes throw the kitchen sink because this can be extremely painful. Botox for this is helpful. And then with the aromatase inhibitor-induced symptoms, PT medication, sometimes NSAID. Cymbalta has actually been shown to be beneficial for patients experiencing pain with the aromatase inhibitors, and then actually also tart cherry. I'm a big believer in interventions that provide potential benefit and are low risk, and tart cherry, if you don't like the taste, that's it. But the recommendation is 1 ounce diluted in 8 ounces of water. I tend to tell patients, let's do this for 6 to 8 weeks, see how you feel, and then keep on doing it if it's beneficial. I'm also a big fan of not being on medications we don't have to be on or supplements, so I don't like folks to just be on things forever. We reevaluate. So case number 2, head and neck cancer. We have a 74-year-old male, history of right tongue cancer, treated with a hemiglossectomy and a right neck dissection, and then unfortunately found to have a biopsy-proven recurrence to the right tongue, treated with cisplatin-based chemoradiation, referred for trismus. So again, in my brain, and you all know now, we're not just evaluating trismus, are we? So with surgeries, with the cancer itself, right, you can have dysphagia, you can have dysarthria, you can have dysphonia. With surgeries, that can get worse. You can obviously have a post-surgical pain syndrome. With neck dissections, essentially they're taking out lymph nodes in different zones of the neck, so you can develop lymphedema. These types of surgeries can also either nick, completely remove, or irritate the spinal accessory nerve, so you can have atrophy into the shoulder girdle, you can have winging of your scapula, and you can have limited shoulder range of motion. Chemotherapy, again, peripheral neuropathy, fatigue, and then radiation. For here, I see a lot of trismus, again, that inability to open up your mouth that can be incredibly limiting. There are patients who, right, have like 5 millimeters. The norm is 40 to 50, or 3-finger rule is what I say. And if you can't open your mouth, you can't eat, you can't brush your teeth, you can't speak, right? So you can understand how incredibly limiting, not only for patient self-care, but their social interactions, right? They don't want to go out with their friends to eat if they can't, right? They can't do all these types of things that can be incredibly limiting. And then also, importantly, it can limit cancer surveillance. If you can't fit a scope in the mouth, they can't surveillance for cancer in that way. So this is something that I try to target really quick. We get patients into therapy, depending on where you're working at. It can be speech therapy, it can be physical therapy, and then Botox, again, not FDA approved, but we get around it. But cervical dystonia as well is kind of like a bucket term, I feel. I use it again so that I can get that Botox approval. But essentially, it limited neck range of motion. If they get radiation here, it can be extremely fibrotic and can limit how we're able to turn our heads. And then again, lymphedema throughout all of this. I feel in the head and neck cancer world, it's a little bit not trickier to treat, but maybe trickier to diagnose, because it's not like your patients with breast cancer who will have one arm that is swollen, right? It's the head and neck area. Is this post-surgical swelling still? Is this just kind of like how they were? I mean, I feel like I have a little bit of a swelling underneath my neck here. And so that's problem number one. Problem number two is that it can be internal as well. And how do we diagnose that? That's really difficult. So it really takes having these concepts in your mind to understand that this could potentially be a reason for your patient's neck or jaw or face swelling or their dysphagia. And then again, we get them into lymphedema therapy. Thankfully, UCH, we're a network of excellence for lymphedema. We are one of 12 in the world. So that's huge. Network of excellence. We have 65 lymphedema therapists throughout the system and are working on establishing a brick and mortar multidisciplinary clinic for these patients. So good things coming everyone's way. So I don't know what I'm doing on time, but final thoughts here. Cancer rehab really should be integrated and offered throughout the cancer care continuum. And then I think this is going to be a little bit controversial because we are in Broncos territory, but think of me as your Mahomes. He's actually, everybody has to admit he's great, right? He's wonderful. So we're your functional and quality of life quarterbacks. Thank you. Oh, questions? I don't know. Yeah. Tart cherry. So it's 1 ounce diluted in 8 ounces of water, or if you want to do supplements, it's 500 milligrams-ish is the recommendation.
Where do you recommend they get this supplement?
Over the counter anywhere. Yeah, anywhere, yeah. You can find it at like the bigger CVS or Walgreens. And I hate to say Amazon, but like we all use it. 1 ounce of tart cherry concentrate in 8 ounces of water daily, or 500 milligram supplement. I can't remember, there's a study that I can have shared with everybody. So you can know, yeah. So it's for aromatase inhibitor induced musculoskeletal syndrome. So again, like these pains that patients may be feeling when they're on aromatase inhibitors, it's usually diffuse, symmetric. It kind of looks a little roomy, so like a rheumatoid arthritis. Again, not only joints, but can be a carpal tunnel syndrome, can be tendonitis in the hands, those types of things. We don't fully understand why it happens, but the thought is aromatase inhibitors block your estrogen. Estrogen are important for cartilage, and then, right, it causes arthralgias, quote unquote. A lot of these things are kind of murky. We do our best.
So to access your services, you just refer to your office?
Yes, so I've been here a year and a half, and I'm a one-woman show. So I've currently only been seeing, or mainly been seeing patients within the UCH system, but if there's somebody that you want me to, just send me an email. The reason I do that is because, again, over-communicator here, I really want to be able to communicate with the oncology teams and other teams so that we're all on the same page on care. So my email was on here. Can we go back to the last slide? Maybe. I don't think they're listening. I can share my email. Thank you. That's my email there. Doing cancer rehabilitation medicine fellowship trained, I'm the only one. in not only UCH, but Colorado, and obviously like surrounding states, as the map showed, unfortunately, working on getting more people. Great, any other questions? I tried to encompass as much as I could. I could talk for like literally a whole week on all of this, so I'll come back. Thank you.